Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 28, a national analytics strategy and use case, closing the gaps in data to address a pandemic. It will be presented by Gabriel Bratt, Assistant Professor of Surgery, Beth Israel Deaconess Medical Center, and instructor in Biomedical Informatics, Harvard Medical School, along with Sadaka Mahmood, Senior Vice President and General Manager, Life Sciences Business Unit, Health Catalyst. Enjoy the session.
Hello and welcome. My name is Sadaka Mahmood. Joining me today is Dr. Gabriel Bratt, who's our research collaborator at Harvard Medical School. I lead life sciences business at Health Catalyst. I'm a dentist and an oral surgeon. My non-clinical roles have included leading clinical analytics and informatics, along with population health management programs and clinical research at academic medical centers. During today's COVID tragedy, there has been a renewed need for a high-value national data asset to solve some of the big challenges and answer some very difficult questions. These questions are tied to policy decisions, public health programs. In addition to that, vaccine, therapeutic, and diagnostic development, as well as managing patient care on the front lines. In today's presentation, I'm going to talk about our approach to generation of insights using national level COVID-19 registry. And Dr. Bratt will share a use case on effects of chronic anticoagulant use on COVID-19 infection rate. While today's presentation is focused on COVID-19, these learnings and principles can be applied to any other disease areas. Our agenda for today's discussion is split into 3 parts. First part will be focused on observations from the field about current state as it relates to national analytics for managing the pandemic, along with a proposed approach and principles for data use. The second part will include an overview of our proposed solution, that is a national level COVID-19 registry. In the third part, Dr. Bratt will share the use case with us along with analytics results. We will wrap up with key recommendations and learnings, then take the opportunity to answer your questions. Following are the learning objectives for today's presentation. During the COVID-19 pandemic, we have seen more data being available than ever before. The pandemic is often referred to as the first data-driven pandemic. Like in this article published by Bloomberg City Lab. Despite all that, we are still struggling at the national level to get access to comprehensive and near real-time data to inform decision-making in response to COVID-19 at the national and local and state levels. Availability of high-value data is part of the problem. The COVID-19 pandemic has surfaced gaps that go beyond data, such as interoperability, patient privacy, data rights. There are troves of important data like positive COVID results, signs and symptoms related to the disease, sitting in siloed EHRs and labs across different hospitals and care settings across the country. We need this data to help us confront the disease and beyond. There are several national analytics use cases for this data. These use cases include disease surveillance, understanding natural history of the disease because we don't know much about it, assessing specificity and sensitivity of more than 141 diagnostic tests that have been approved by the FDA under emergency use authorization. Then we also look at phenotypic and genotypic presentation of disease using clinical and molecular data, clinical trials, design, feasibility, and recruitment for both vaccines and therapeutics, and understanding efficacy and safety of drugs that are potential treatments for COVID 19. And finally, the impact on other diseases that will probably stay with us for much longer than the pandemic, and diseases as serious as cancer. We have served many of these national analytics use cases in collaboration with our federal and state level partners, including the Regan Udall Foundation for the FDA and Friends of Cancer Research through COVID 19 Evidence Accelerator. In partnership with MITRE, we have also convened the first ever national analytics group with all EHR and analytics organizations across the country. For those of you who don't know about MITRE, MITRE is a nonprofit organization that works in public interest across federal, state, and local governments, as well as industry and academia, to tackle challenges related to the safety, stability, and wellness of the country. Let me share with you observations that I've made working with the national and state level organizations. It is time for big data. Point of care, near real time data is critical for us to react, respond, and also evolve as we continue to learn more about the disease. Research is a predominant care option at this time because we don't have an approved treatment for this disease. Randomized controlled trials are gold standard. There's no denying that, but they're slow. The real world data from the front lines can enhance our ability to evolve and continue to improve our research protocols, research designs, and also expedite our overall learning. Despite digitization of EHRs and meaningful use, authorities still don't have research grade data available for surveillance, for supply chain management, and for many of the regulatory decision making. Data rights, standard terminology, and interoperability are at the core of the issue. We cannot keep building multiple registries at every single health system. They're expensive, they lack standardization, they take too long. They also lack in representation of practice variation and patient characteristics that are critical for us to understand during the pandemic management. There is also a lack of real world experience in the fundamentals of registry design that we often see. Turning data from the front lines into a solid strategy for a registry at a national level is hard. It's not an easy task. The country needs someone to take on ownership, provide guidance, set standards. Federal involvement has been limited to date and may lead to increased burden of data collection and even chaos. We have seen some examples with HHS requiring hospitals to submit data in the recent months. Most healthcare organizations have underutilized data models that draw from multiple healthcare source systems to aggregate data, but lack of reusable and common data models prevents scalability. Lastly, innovation, agility, and resilience are key during these times. With these challenges and observations in the back of our minds, let's discuss considerations for a potential solution, like a national data registry. There are five key considerations that I would like to put forward with you all. The first one is building an ecosystem that includes various stakeholders, disparate organizations coming together, bringing their unique perspective. We are in unprecedented times. We cannot win this alone, and we have to work together. Second is data rights. With patient consent, alignment with privacy provisions, and appropriate data rights to exchange information, we can connect the dots and get a full digital picture of the patients. Now, to connect these dots, various sources of data that include variety of information about a patient, we need a national patient identifier for matching. Our recommendation is that Congress should repeal the long-standing ban on NPI and direct the ONC to develop an NPI. This is the time to do it. The next is technology infrastructure to enable data exchange. This is a critical component because without data infrastructure, nothing else matters. As we move towards interoperability, we need to develop a common nomenclature for collecting and reporting key healthcare data for COVID-19 and even beyond that for other disease areas. Now, with a functional registry, we need to be able to create a patient digital twin that allows pattern recognition. And there are three key fundamentals here: patient pairs that have similar characteristics, then those who are treated and managed the same, and then finally those who have similar outcomes and costs. It is more about patterns at this point in the pandemic than prediction. Let's talk about principles for data use. In current environment, it is important to establish principles so we can operate with credibility. These principles are not perfect by any means, but they provide a starting point. Our principles are as follows: respect patient privacy, especially when there is a tremendous exchange of data and data that our patients have trusted us with. Ruthless transparency in the process and the analyses. Traceability and provenance of data acquisition, processing that goes behind the scenes, curation, as well as analytics. Account for the realities of clinical practice and the voice of our providers from the front line. Continuous learning throughout the process. Dissemination of insights and evidence being considered a serious responsibility. And then lastly, being agile, acting as fast as we can, but not compromising on quality. To put data to use, the first step is hypothesis generation. Hypothesis generation is at the heart and beginning of basic and applied research. In my observation, hypothesis generation during COVID-19 therapeutic space has been chaotic. Vaccine research is much better. We need a process for brokering and prioritizing therapeutic hypotheses that could then be used to drive the priorities of our data collection and analyses. There are three areas to consider here as we think about hypothesis generation. The first is involvement of the right stakeholders in the process. Stakeholders that are methodologists, clinicians, also public health authorities, and regulators. Second is learning from existing evidence that we have access to. And finally, finding patterns in the data to inform the hypothesis, data that is available to us as of today. In summary, we have talked a lot about having access to national level data. It is not just about having the data, it is about having quality national level data that comes with provenance and transparency of the process associated with the data collection and aggregation. Why is this important? You all know the answer to that. Let me share a recent article here from 2 months ago that highlights two studies that had to be retracted due to issues with quality, transparency, and provenance of data by New England Journal of Medicine and Lancet. Now, in the next section, I want to share with you an overview of our COVID-19 National Registry that supports our collaboration with the Reagan-Udall Foundation for the FDA, Friends of Cancer Research, and MITRE Corporation. Here is a quick snapshot of the registry and the data that is powering national analytics use cases. This registry contains more than 1.7 million patients with some symptom and testing involved with COVID-19. This registry is based on our data platform that is an integrated repository of data from across our national provider customer base, as well as includes third-party data sources. So think about Medicare claims. The combination of data from across such a large group of provider organizations and the depth of data that is available is unprecedented. The registry includes core data components like encounters, diagnoses, medications, labs, clinical notes from the EHR, and also includes claims information, some genomics information. We have a variety of users supporting various use cases with this data set. We have used this data set to focus on benchmarking and organizational comparative analytics, as well as research use cases. And research use cases for patients like this, which amounts to finding digital twin of the patient for specific insights and analyses. More generally, the interest in clinical research has been increasing as it relates to this data set. Finally, and most importantly, national and state levels policymaking and public health surveillance has been brought to the forefront with the analytics we have been able to provide. You have seen us talk about analytics maturity model in the past. We are applying the same principles and concepts from analytics maturity model to the data maturity model for research that you see on the screen. This is more to plant the seed with you all at this time, and we'll come back to this hopefully during that next HAS in 2021. The beginning of every analytics use case of value in healthcare and research starts with a precise definition of the patient type as defined by the data. Managing COVID-19 also starts with understanding and defining COVID-19 patients. It is challenging for several reasons. We have spent hundreds of hours, if not thousands, in defining these patients, in addition to defining the outcomes. We're being thoughtful about patient registries and are defining these standards at the national level. There are two primary patient types that we have defined: suspected and confirmed patients. Our suspected patient category is further broken down into low, medium, and high based on a heuristic model. We accounted for symptoms and viral exposure in this category. The details of the definitions and the value sets behind these two patient types is published on our website, and I invite all of you to visit it and provide us feedback after the session. This slide summarizes all that goes into generating national level analytics for COVID-19. I want to draw your attention to two grand challenges that we have faced nationally. One is standardized terminology, and second is data curation. If we only look at our data in the registry and in the overall data platform that consolidates data from all of our customers, we see the following. Of 3 billion lab tests results associated with 38 million patients, only 6% have a loin code. So what is the solution to that? Requiring standardized terminology in lab information system results, also known as LIS system results, and EHR orders can solve this problem for us. Lack of standard terminology leads to costly, slow, and imprecise curation detection work. Here are two examples that I've included for you. Let's look at the test names. There are plenty of misspellings that we see in the data that leads to curation. And then let's look at the results value. My favorite there has been patient left for Florida. What do we do with that? We have to clean it up and think about how to best account for that in the data. Not very useful. Now, at the beginning of the talk, we discussed the need for a national registry to support analytics use cases. Then we talked about the requirements of the registry and hypothesis generation. We have also discussed the national registry that we have built with these considerations. In the next section, I'm pleased to introduce Dr. Brad from Harvard Medical School, who will talk about a specific analytics use case using these principles that we have discussed so far, and particularly looking at patient like this concept. Thank you very much. Over to Dr. Brad.
Thank you, Sadika, for the opportunity to present our work on chronic anticoagulation and COVID-19. My name is Gabriel Brad. I'm a surgeon and intensivist at Beth Israel Deaconess Medical Center and a faculty in the Department of Biomedical Informatics at Harvard Medical School. We were inspired to look at this question during the height of the COVID epidemic, where we were seeing that patients were not presenting with traditional findings of viral pneumonia, but actually had atypical courses that were more consistent with inflammation and coagulopathy. And as time went on, people started to have similar findings and were publishing on this, where what they could see was that when autopsies were performed, instead of finding severe inflammation in the lungs, what people were finding were blood clots in the small vessels of the lungs that were causing this severe presentation. And as time has gone on, it has further borne out this data, where as recently as a few weeks ago, a Nature Medicine paper showed that COVID-19 infection results in a robust activation of the complement and coagulation pathways. From that kind of presentation, we asked ourselves what seems to be a somewhat obvious question, which is that if patients were dying of blood clots, then could blood thinners have an impact on their course? And so the fundamental question that we started with was, do patients on chronic blood thinners before they come into the hospital have lower rates of symptomatic COVID-19, which we identified as being a COVID positive test, relative to matched populations? So we began by identifying a set of anticoagulants and antiplatelet agents. And we chose to break them into two groups because fundamentally, these two types of drugs have different mechanisms of action. What we then did was we spent quite a bit of time carving out heparin as a drug because As those who are involved in the care of many of these patients would know, heparin is used for other functions beyond simply blood thinning and is often used for keeping the patency of IVs or also managing the ports that patients might have. And so therefore, after doing our data extraction, we carefully identified this exposure for antiplatelet and anticoagulants. We then, as part of our data extraction, we pulled out the demographic characteristics of patients, which would include age, gender, and race. We pulled out all of their outpatient medications via information on outpatient and home medication flags. We identified their comorbidities and then bucketed them into specific subsets based on data from the COVID-19 Interoperability Alliance. We also derived a frailty score that was first published in 2018, where we looked at the comorbidities and functional ICD-10 codes for these patients in order to characterize not only what their comorbid conditions would be, but a sense of frailty so we could effectively control for it when comparing these populations. And in order to ensure that our patients were interacting with the hospital system in a way that was consistent, we looked at and identified key statistics of fact count, which is the number of times that some bill or interaction has been performed with the healthcare system, the number of encounters with the healthcare system, and then the number of inpatient encounters per quarter. Finally, as our outcome measure, we looked for patients who were RT-PCR negative and positive. So the status of their COVID-19 was what we used as our outcome. And in order to derive a group that would be relatively consistent, we ensured that our patient population had certain characteristics that were the same. And specifically, across the 7 million patients that we evaluated, we wanted to make sure that they had at least 2 encounters in 2019, and that at least one of those encounters was in the third and fourth quarter of 2019. What this would do is allow us to identify patients who were regularly interacting with the healthcare system, as opposed to patients who might have gotten the medication a year ago and then are not involved at all in further evaluation. What this would do is ensure that the patients that we're actually looking at are patients with significant disease, as opposed to patients who might not be sick relative to their counterparts. For the methods, we then use something called doubly robust methodology to control and characterize our confounding. And as an overview, basically what we did was we used propensity score modeling, where we looked at the differences between the exposure and the control group. And then we did the same thing for the outcome model as well. And then we identified both of these populations and both of these models. And if either of these models was functionally consistent, then it was unadjusted. Whereas if there was any need for adjustment, then we would characterize it within the model itself. And we use something called a superlearner machine learning model, where we combine certain machine learning models in an optimal fashion in order to fit both the outcome and the propensity score models at the same time to get an optimal fitting model for the confounding that we were concerned that we would have. Now, once we had built this model where we could control for our exposure, which was our anticoagulants, and we could control and effectively control for the confounder and the outcome as well, we then realized that despite all of this, we might have some residual confounders, that there might be patients who are more sick in one group relative to the other group. And so what we did was we chose to identify a subset of medications that are consistently identified and used in these populations. And what we did was we compared the patients who are on anticoagulants with or without the anticoagulant on the specific medication. So at least that the medication was consistent. And I'll talk a little bit more about that in a few minutes. What did we find? So overall, as I mentioned, there were 7 million patients. The rate of COVID-19 positivity in that population was about 0.1%. Among antiplatelet patients who were taking antiplatelet agents, the rate of COVID-19 was 0.7, and among patients who were on anticoagulants, the rate of positivity was 0.9%. I just highlighted a couple of other characteristics just to show you that overall the populations were relatively similar, but the patients who had a history of cancer were more commonly of anticoagulants, and the patients who had a history of MI or cerebrovascular disease were more commonly on antiplatelet. This is absolutely consistent with the use cases of these medications, where they overlap significantly between the two groups, but certainly it is more common to be prescribed one versus the other for different diseases. Then what we did was we looked at a subset of medications. As I mentioned, we looked at statins, metformin, metoprolol, famotidine, amiodarone, digoxin. These are relatively common medications in these populations. And I'll take, for example, metoprolol, which is a medication that is commonly used for people with high blood pressure. And as you can see, the rates of use of metoprolol in our antiplatelet agents and our anticoagulant groups were relatively similar, but they did have some differences. The idea being, though, that if you are a patient who is on metoprolol, then you are more similar to another patient who is on metoprolol and an antiplatelet agent than one who is not on metoprolol. And so we use the comparison for medications to give us a better sense of and consistency across our populations. So overall, our findings were that if a patient, after significant adjustment for confounding, if a patient was on an antiplatelet agent, their risk of developing COVID-19 positivity as identified by PCR was significantly less than people who were not on antiplatelet agents. And so, for example, if you were on famotidine, which is a drug that's used for acid reflux disease, or you were taking metoprolol, as we had mentioned previously, for high blood pressure, your risk of developing an identifiable COVID-19 disease that is symptomatic was lower than if you were not on antiplatelet agents. And so therefore, what this suggests is that for a subset of patients, it is very possible that the use of antiplatelet agents may have a small but real effect on the presentation of these patients. Now, as you can see, these differences are pretty small. And so the risk ratios are robust because the populations are large. But overall, we do see only a small effect. That effect is clearly exacerbated when you're on medications that are associated with anticoagulants. And those effects are very much don't appear in our data when we looked at statins or metformin. From this, we believe that there is a promising opportunity to evaluate the effect of anticoagulants in the presentation of patients with COVID-19. And what we found was that if you were on antiplatelet agent, you had a small but significant reduction in your rates of COVID-19. What this allows us to do is to further extend this thought process, and we're currently in the process of doing so, from what we're seeing in the outpatient to what we look for in the inpatient. So not only are we looking to see if the effect existed in the outpatient, but whether then it translated to the inpatient setting. There are clear limitations to this project. There's clearly the possibility that despite all of our controls, there could be confounders by indication because patients who are on one drug versus another may have increased or lower rates of the disease. It is possible that there are socioeconomic effects that we can't appreciate and we weren't able to control for. And it is possible that there are increased death rates in one population versus another. However, the reality is that for most of these effects should work against our finding, not for our finding. And so therefore, although it is small, we think that the limitations are such that with all of the control that we put in for confounding, that we're seeing a true effect that we hope to reproduce as we continue to look throughout the care continuum for our patients. Thank you very much.
Thank you, Dr. Brad. Now it's time to wrap up. Before I share what we have learned and our recommendations for national level analytics, I would like to thank the many organizations across our network who have provided data, and also our national partners for their expertise to make the National COVID-19 Registry a possibility and a reality. Here's what we have learned and our recommendations. We have established today that troves of patient data, when harnessed in an automated, real-time manner, can be used by health systems, states, and federal government to predict surges in COVID-19, to determine which patients are more likely to get acutely infected, and to provide healthcare systems with risk and severity adjusted information to predict other findings. It also helps with drug discovery process and informing our ongoing clinical trials. With the breadth and depth of data that we shared as a consideration, it's important for us to take that into account to run national level analytics. This data will also inform population health and public health, including vaccination programs once the vaccines are out. These principles we've talked about today at the national level can be applied globally to several disease areas. Thank you very much for joining us today. We look forward to hearing your questions and hopefully answer them in a meaningful way.